A very good afternoon, everyone. In this video, we'll talk about the clinical features, complication, and differential diagnosis of the cardiogenic shock. And at the end of the video, please like the video, share the video, and subscribe the channel. And do not forget to press the bell icon. Thank you again for watching the video. The clinical feature of the cardiogenic shock, they largely depend the way the patient presents in the emergency department or intensive care unit. There are two forms of presentation. Sometimes, though they are lesser in number, sometimes cardiogenic shock is present on the initial presentation. And sometimes the patient present with the myocardial infarction, both ST elevation and non-ST elevation. And later on, during the admission, the patient develops the cardiogenic shock. Those patients who initially present with the cardiogenic shock, they may have cool extremities because of the low blood pressure. They may be having sweating because of the adrenergic system activation, and for the same reason they may be anxious. Their skin may be pale and yellow because of the hypoperfusion of the vital organs, including also the skin. These patients, because of the low blood supply to the kidneys, may develop low urine output, and because of the low blood supply as a result of cardiogenic shock to the brain, these patients may also develop the altered sensorium. Now, when the patient presents initially with the myocardial infarction, then the clinical features of the cardiogenic shock will be preceded by the clinical features of the initial presentation. There may be a sudden onset of the chest pain. There will be abrupt onset of the substernal chest pain or heaviness. Patient will be putting the fist on the chest. There may be pain in the left arm or the jaw, or this pain and heaviness can be radiating towards the left arm and the jaw. There may be extreme sweating or the diaphoresis. Sometimes inferior wall MI presents with the pain epigastrium, and these patients may have nausea and vomiting. But elderly and women patients, they have very atypical symptoms like the shortness of breath. Talking about the complications which happen as a result of the cardiogenic shock. Now, because these patients, they have got an ejection fraction which is mostly less than 25%, so that puts them at a higher risk of arrhythmias, where the heart loses the normal sinus rhythm and develops either supraventricular tachycardia or ventricular tachycardia or atrial fibrillation, because the normal focus is lost by the decreased ejection fraction or low contractility of the heart. As a result of the same phenomena, because there is low contractility of the heart, so there is a increased propensity for the development of the thrombi, and they can end up in the brain and can result in the ischemic stroke. Sometimes these thrombi also go to the peripheral vascular system and cause there the peripheral vascular disease, including the ischemic gangrene, or they can also cause the ischemic gut. And sometimes these patients, they have got a hypoperfusion of the vital organs of the body, so they end up developing the multi-organ dysfunction syndrome, which is known as the MODS, and it's a dying process. Whenever a patient goes into the MODS, that means patient is on the path of death. This is very important to remember. And because of the hypoperfusion of the kidneys, there will be a decreased functioning of the kidney, decreased urine output, and ultimately it will result in acute renal shutdown. And sometimes, because the wall of the heart is quite brittle or weak, and when the heart is trying to compensate for the low cardiac output or low stroke volume, it increases its heart rate, which puts extra pressure on the ventricle. It can cause the ventricular aneurysm. And lastly, these patients ultimately can develop the cardiopulmonary arrest and even die of this complication of the cardiogenic shock, because heart is trying to supply the rest of the body at the cost of its own weakness. Lastly, these patients, when present to the emergency department or intensive care unit, they have got clinical features which are unique to so many other diseases. Like when they present as a chest pain, when they present as an anxious patient, when they present as a patient who has got the shortness of breath. So there are a group of the diseases with which the patients come with the same sort of the complaints. This is known as the differential diagnosis. As long as we haven't carried out certain tests and certain procedure on the patient, will not be sure of the diagnosis of the cardiogenic shock. So always remember, whenever you receive a patient with the clinical features which we just discussed, there should be a group of the diseases in your head which we will call the DD or the differential diagnosis. These may be the myocardial ischemia, which includes not only the ST elevation MI but also the non-ST elevation MI and unstable angina. It can be the massive pulmonary embolism, septic shock, hypovolemic shock, cardiogenic pulmonary edema, myocardial rupture, and systemic inflammatory response syndrome, because in systemic inflammatory response syndrome, either two of the four should be present, like respiratory rate needs to be more than 20 and RDP CO2 should be less than 32. Heart rate needs to be more than like 90 beats per minute, and either the TLC is more than 11,000 or less than 4,000, and either the temperature is more than 100.4 or less than 96. So it can be any of the differential when a patient presents with the those clinical features which are related to the cardiogenic shock. So always think of these diseases at the presentation and then try to exclude them or rule them out one by one.